Everybody, welcome to the Finance Committee meeting for the Health Commission. I'll ask the secretary to please call the roll.
Yes, I'll start with you, Commissioner Chow,
Present.
and Commissioner Guggenheim. I'll note that Commissioner Guillermo is on her way. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. All right, we can move on to item 2, which is the approval of the November 3rd committee meeting minutes.
So the minutes are before us for approval. Is there a motion?
I so move.
And I will second.
Is there any public comment in the room on the item? I see no public comment and no one got permission to have remote public comment. So all those in favor?
Aye.
Aye.
All right, thank you so much. We can move on to the monthly contracts report.
Good afternoon, Commissioners. Kim Baker. I am the Director of the Office of Contract Management and Compliance, and I'm here to go over the monthly report, contract report with you this afternoon. We have a fairly short number of items today. We have 3 items on the monthly contract report, and then there will be 4 individual items that will be presented by the business program owners for new contracts. Okay? So the very first one on our list today is a contract amendment with the San Francisco AIDS Foundation. This contract amendment is going to be for Health Access Point HAP services. As you may recall, last month we brought 6 of these HAP contracts forward. This one particular one with the San Francisco AIDS Foundation lagged behind for a month to clear up an item, an added scope item that we had to go over with our legal department. This contract amendment adds $13 million to the contract for a revised contract total of just under 25 million, 24.9 million. This is going to be for an extension to the contract term of 4 years, which will take us into June 30, 2030. Again, as I mentioned, this is Health Access Point HAP services for gay and MSM communities in San Francisco. And this contract is subject to approval of the Board of Supervisors. By the Board of Supervisors. It does have a slight annual increase of 1%, about $30,000, and that's just for the annual cost of doing business increase. As you may recall, the HAP program does a lot of different things. So I'll quickly just go through those again for the public. It provides clinical assistance services, prevention and medical and treatment medication, integrated testing, harm reduction services, overdose prevention, syringe access and disposal services, condom distribution, community engagement mobilization, basic needs services, which includes hygiene supplies and food, prevention and treatment medication, mental health services, primary care services, substance use treatments, capacity building and workforce development, capacity building activities that support the HAP network. This particular contract is 100% general fund. I know there's a long list of all of the different charges, the amounts per test and so forth. And I know there were some questions that were asked this morning about the number of clients served, number of services, and about the capacity building. And you just literally received answers to that about 30 minutes before the meeting. So I do have Nicole here with me, and she can help us if you have any questions about that information that you just received. The last thing I was going to tell you about this contract is that it is monitored by the Office of Contract Compliance. And it did receive a score of 4, which is considered commendable, exceeds standards. They met 100% of their performance objectives and units of service targets. And the organization was deemed to be in conformance with their fiscal monitoring. And I know there were some questions asked about that. It looks like San Francisco AIDS Foundation has addressed some concerns in the past and expects to break even this year. They're on a good trajectory to be in good shape this year financially. Any questions about this one or anything you want to go into more depth on specifically?
Commissioner, questions? Well, I want to get back to the question of the services, because I mean, there's a whole list of services.
Yes.
And it would be nice to understand how many we are doing or
Okay.
who we're touching, and just simply listing what the employee costs are or the personnel costs are doesn't give us an impression as to what is going on.
Got it.
And what we're doing. So
Okay.
that's what we would like to ask. When we say deliverables and unduplicated clients, we expect to see what is expected and how or for what reason we've marked 4, whether it's just simply that we held 10 capacity building classes and that gets a 4, or there were 500 people in them and, 250 of them are working or still working. So more the outcomes of what are the key services that we're performing here. And number 2, we continue the same level of capacity building activities throughout the whole contract. So I'm not sure if we've already built capacity, then our hope would be that that capacity retains itself, or is it that we have new people every year that we have to do this for?
Got it. Okay, let me bring Nicole up and let her address some of those specific questions.
Okay, thank you.
Of course. Good afternoon. I'm Nicole Trainer. I'm the CHEP Budget System of Care Budget Contracts and Program Operations Manager. And so I oversee all the contracts within CHEP.
Yeah, could you speak up just a little and then,
Sure.
and can we have the,
Of course, yes.
yeah.
I apologize.
I'm kind of tall here. What about?
Yes. Great. We want to hear what you're going to say. So,
Of course, of course. And Commissioner Shaw, you always ask really great questions, so I always appreciate them. So for the contracted piece, CHEP has changed. With the health access points, there's 13 standard of care services, and they're designed to be fluid in how you provide those services. And what we found that when we put in the contracted number of clients, it's really hard to back into that. We don't necessarily have a formula for that, right? It'd be the CBO saying, this is how many clients we see per year. We estimate this number of clients. And so CHEP really wanted to do something more forward and get actuals. And so we left those numbers as NA in the contract because now we collect client level data and aggregate level data biannually, which tells us the actuals of clients they are seeing and unduplicated clients for the services that we are providing, especially for the services that are allocated 1 units of service equal 1 month of service. And so that UOS seems a lot for a service, but it's providing the fluidity of those services throughout the month. So I did provide you with some breakouts of what those numbers are. So for the integrated testing, we did have a contracted amount for that because that's easier to back into because that's the core function of the HAP. The foundation was contracted to do 27,000 tests with 10,200 number of clients. They actually exceeded that. They've performed 81,000 tests. And that's also the number of clients they're still providing that data, but essentially per each test, there were some clients that were continuing to get testing on a 3-month basis. But essentially, they provided full panel sexual STI testing, which includes HIV, chlamydia, gonorrhea, and syphilis. for 81,000 tests. For the linkage and navigation, they were contracted for 865 clients. They've actually exceeded that and referred 8,772 clients to different various of services. Of that 8,000 clients referred, 5,000 of those clients were actually successfully linked to services. So refer is like, I'm giving you some information, go to this place for housing services, employment services, and the actual linked are the clients that we can verify that were connected to an agency and actually receive those services. The number of clients that were navigated to either HIV, HCV, STI, PrEP, mental health services, or substance use care services were 5,062 clients. For their community engagement and mobilization, they were contracted for 276 number of clients. They exceeded that, where they performed 39 community-based events, and they reached 3,500 clients. And for our HIV health education prevention counseling, again, this is a service that is very fluid within the HAP access. So if I come in and get testing or need basic needs, the HIV education and STI education is also implemented during that contact with that client. They linked or provided integrated HIV testing or health education to 1,583 clients. And for prevention and treatment and medication, the number of clients that initiated PrEP, which is 20. And so PrEP is a pre-exposure prophylaxis, the daily pill that prevents HIV. And number of clients initiated ART, which is HIV antiviral medication, was 1,413. So these clients were either tested positive for rapid testing or fell out of care and relinked to new treatment or linked back to care services. And they also distributed 41,536 condoms annually. The foundation, what's listed here is in-kind services. They also provide, that's not listed in their contract, meaning that they get funded to provide these services in another contract. We want to ensure that there's no double dipping. However, because the HAP is so fluid, it makes sense for them to leverage those other funds to also provide to clients. That includes the harm reduction services for substance use, syringe access and disposal. They collected 1,640 syringes. They also did 78 hours of syringe sweep throughout the entire city. They provided 283 naloxone distribution, and they provide substance use treatment. They've also provided basic needs services. So if clients come in and they need food, they need clothing, they need access to medication storage, they need transportation. It's a variety of basic needs services they provide, and they serve 6,009 clients. And for their mental health services, we put there's 0 NOC because those are folded into the linkage and care services. So they don't provide mental health on site, but they partner and link folks to mental health services. And they also link people to primary care who don't have a primary care home. And so those were the numbers you were referring to, Commissioner Childs. So I do want to let you know that biannually, the foundation is required to send us client level and aggregate data. And so we don't put that in the contract, but we do have that data readily available, and we're in the process of validating year 2 data.
Thank you. I mean, you understand that when we're asking
Of course.
for the deliverables and unduplicated, it wasn't just simply the personnel. And that's really helpful to understand the breadth of work that they're doing.
Sounds good. I do want to address your capacity building questions because they were very important as well. There's 3 different capacity building components in this contract. One of them is the integrated integration of HIV, STI, and HCV testing. This is a capacity building effort that we do foresee to be ongoing for the next few years, only because this is one of the core functions in the health access points. And there's 7 leads and there's 9 subcontractors. And so the goal is that within every lead health access point and within every subcontractor who provides the same services to ensure that we reach all 4 corners of San Francisco, is that they, one, have a CLIA license and one that is sustainable. And that can be somewhat challenging for smaller organizations because a CLIA can be costly. You have to have a physician on board. And so we want to make sure that we're providing that capacity and ensuring that those services can sustain themselves when we pull that capacity building services. So we don't want to pay for this and then get to a point where they can't sustain it. It will be a waste of our investment. So the goal is, you're right, is to scale back once we meet those major milestones. But we foresee the capacity building for testing to be something that's ongoing for different agencies who come within the Health Access Point network. So for the Rafiki capacity building support, this was implemented through, we did a needs assessment, and we know that for some agencies who serve communities that have a higher burden of disease or typically serve communities that were historically oppressed in San Francisco, we want to ensure that Rafiki had the ability and they were successful in serving all Black African Americans in San Francisco. And we all know currently the current state of health disparities across the continuum of care. And so what we found is that Rafiki needed assistance in organizational infrastructure, administration, also with their testing, implementing a new clinical site, as well as staffing and recruitment and retention. And so far, we've met some major milestones with the technical assistance of the foundation. They have a new clinic at 5000 3rd Street that they've built out. They're putting mental health services there. They're in the process of hiring a new clinician. They're in the process of also getting a CLIA, and there are 2 staff from the clinical assistance program that were placed at Rafiki. So they are making great progress. And as you mentioned, we are in conversation around how the funding that we provide to the foundation could potentially scale back, and possibly there be a new relationship with Rafiki and the foundation to continue the support to ensure that they continue to elevate. And that's the same for the workforce development. Right now, the foundation is training about 10 individuals from the community that to provide services. They get trained in health and HIV test counseling services, essentially the gamut of being a public health practitioner. We want to ensure that we're hiring folks and training folks who look like the people they serve. We know that works. And so again, you mentioned about at what point do we know that we're capacitated, and that is something that we're reviewing to ensure that when's the best time to scale back to ensure that those the workforce development piece is sustained. We don't want to pull out too soon where all the work that we've done just simply collapsed, but totally agree with making sure that on an annual basis, we're doing an assessment of what capacity building looks like for the next fiscal year. And so what you see in that contract are for the future years are those placeholders, right? And so when we have these conversations, we will definitely adjust what that looks like in the funding, in the contract funding notification.
Thank you. That's extremely helpful to put some numbers and faces basically behind these numbers.
Of course.
Commissioner Guillermo, I know you just got here, but you probably got the gist. We were asking what were the products really that were coming out, and there's just a whole host of projects. So do you have any questions? Okay, any further questions?
No, I was going to ask, are these the only services available for testing and for treating? And when you answered the question, so thank you.
Welcome, of course.
Okay, well, thank you. Like we were saying, you know, what really does the 3 million produce? And that's really the questions, and
Yeah.
trying to define it sometimes is very hard within the categories. So
Absolutely.
really appreciate the work that you put to bring to us this. And I think in the
Thank you.
future, when such contracts appear, we really need to make sure that we are looking at products
Yes,
and
yes.
outcomes.
Agreed. And thank you for the great questions. And our branch will continue to provide you with data as we bring contracts before you.
Thank you.
Thank you.
We'll go on to the next contract.
Readjust for the short people here. Okay, so our next item is also a contract amendment, and this is with the YMCA of San Francisco. This amendment is for $2.2 million, and it's a one-year term. And this is going to continue to provide outpatient specialty and mental health services to eligible youth up to 21 years of age, including youth referral from the San Francisco School District. This particular contract is also subject to approval of the Board of Supervisors due to the value. The increase is taking us to $12 million. There was an increase, a pretty significant increase in the annual funding that you asked questions about. And the information received from FARA is that they're expanding the outpatient specialty mental health and ER/MHS services with those dollars that were repurposed. It is a fee for service. There's 111 unduplicated clients. It is 35% federally funded, 35% state, and 30% general. This particular contract is also monitored by the Business Office of Contract Compliance. It does have a score of 3, which is acceptable, meets standards. 68% of its performance objectives were met. It was exempted from the units of service target, and there are no findings of financial compliance side. The only real reason for the 3 that we went over when we presented this with Dan is that they have trouble getting the customer surveys completed because this is for children, but their parents have to fill out the customer surveys. So it's a little bit of a challenge to get the parents sometimes to complete those surveys. So they're working very diligently on new plans to get those surveys completed. But that was the primary reason for the 3 and not a 4 on this particular one. So any questions about the YMCA?
Commissioners, questions? Yes, Commissioner Guillaume.
Thank you. I was just wondering, so the extension is being requested for 1 year. Why is that extension requested? And will it come back at some point for the typical sort of contract renewal, or is there going to be another bid process?
Let me bring Farah up to talk about that part.
Hi, Commissioners. Our outpatient contracts are all going out to bid for new contract start dates in fiscal year 27-28. This contract was going to the board because of the increase that tipped it over. So we needed authority regardless of that extra year. But I believe the business office was just allowing it a year buffer just in case there needed to be an extension. But in theory, this contract will be part of our mega RFP of all outpatient services that are going out to bid for new contract start dates 27-28.
Thank you. And so just to be clear, even though the extension is only for this additional $2+ million, if the total contract goes over the 10 million, then even though the previous contract was approved under 10 million, so what if they didn't approve it and we've already spent the money or we've already provided the funds? It's just sort of I guess, a technical question.
I think it got tipped over for the increase of 185,000 from we moved 185,000 from a different program that this provider delivers, where there was less of a need in terms of referrals, and we moved it over to this outpatient contract, and that's what's tipping us coming back for authority. I don't know if I answered your question.
No, the question is, since the previous contract has already pretty much expired and we're asking for an extension that tips it over, what happens if the board does not approve this extension and the additional amount, given that the prior contract was already approved and it's, sort of done
Right.
with? It's just a technical question.
Yeah, so technically, I guess if it didn't get approved, then we'd have to do just a shorter amendment to pay them whatever was due. So if they had done like a month of service or what have you, we'd have to do a shorter amendment to get that approved. But typically, we don't have problems getting them approved. We do answer a lot of questions for the Board of Supervisors, but once those questions are answered, they typically do get approved.
Okay, thank you.
Commissioner, question?
I'm not sure whether I really want to ask this question because I might just not be very smart, but how are you measuring success in all of this?
Sure. So we've got standard performance objectives for all of our outpatient specialty mental health providers. So they get monitored annually by the Business Office of Contract and Compliance on those standard objectives that all outpatient providers get monitored to.
So do you also monitor the patients who get who are part of the program? Do you have a measure of success for them?
Yes, I lost my talking points, but we do have tools. DHCS, the state mandates 2 different outcome tools to be delivered every 6 months on all youth that are in our care. The CANS, the Child Adolescent Needs and Strengths, and the Pediatric Symptom Checklist 35 are delivered every 6 months. So there's outcome measures related to those tools in addition to other monitoring objectives.
So, Commissioner, I guess the issue would be that you don't know what the parameters are, but they do, and I guess they're saying that they were fulfilled, so.
Okay.
Any other questions, commissioners?
I don't see any other questions. We can go on to the, and thank you for the response in the written responses that you provided for the contract report, because that's helpful.
No problem. Okay, so the very last one is a new contract for continued services with UCSF Courts Program. This is a new contract for $9.8 million for 4.5 years. And I think there was a question asked about this particular contract about the annual cost of the previous program. So these were under 2 different contracts. They're being combined into one. And we provided that information. The previous cost for the 2 contracts was $1.3 million each. For each of the 2 programs that were combined, AOT and Care Court. So it was originally 2.6 million in the past. So this program is specifically related to the courts, and it's for adults with severe mental illness who are struggling to stabilize themselves in the community, and are declining care. It provides intensive level of outpatient support through the citywide AOT care team. So the treatment is, there's 40 unduplicated clients. There was a question asked about how long each client remains in treatment, and the answer given in the written response was 6 to 12 months. And the referral process is through readiness for engagement in court status based on some legal criteria that's outlined for the program. It is 26% general fund, 36% state fund, and 38% Medi-Cal. This contract is monitored by the Office of Contract Compliance. It has a 4 commendable exceed standards rating. 80% of its performance objectives were met, and it was exempted on its units of service target. And there is no fiscal monitoring. Since it is another governmental agency, we don't do fiscal monitoring on governmental agencies. So that is UCSF Courts Programs. Do you have any specific questions about this one?
And commissioners, just to note, the response has some corrected and expanded data on, so maybe take a look at it before you might ask a question around looks like around funding.
Yes. Well, that's interesting. The merge program costs less. Is there a reduction of the work we're doing, or it's right sizing it to the work that is being done?
I believe it's right sizing it, but is that correct? Yes.
Okay. All right. I mean, it's an important program, so we don't want to
Right.
short something that is really helpful to the courts and to us. So, questions, Commissioner? Any question? No questions.
Okay, great.
Thank you very much.
Thank you very much.
Go on to our next item.
Yeah, well, so would you consider a motion to?
Oh,
amend
that's
to the
right.
full
This is
committee?
the end of the
Yeah.
three. It's so nice to have only three.
That's right.
All right, it's a motions in order to recommend the contracts report to the commission.
I'll move,
Second.
approval.
All those in favor?
Aye.
Great,
Aye.
thank you.
Thank you.
Thank you. Item 4 is a request for approval with the new professional services agreement with UCSF to perform day treatment, intensive and specialty mental health services.
Hi again. Good afternoon, Commissioners. I'm Dr. Farnaz Farman, the Director of the Children, Youth, Family System of Care. Thank you for hearing this contract today. And with me remotely is Dr. Barbara Stewart from UCSF, who's a professor of clinical psychiatry and behavioral science at UCSF Department of Psychiatry and the Vice Chair of Psychology, Clinical and Education, and the interim Director and Deputy Director of the Division of Infant, Child, and Adolescent Psychiatry, in addition to being the Training Director of the UCSF Child and Adolescent Services Multicultural Training Program. So she's wearing quite a lot of hats, and she's here with us to support any questions you have remotely. So this is a new contract going to you all, and it's actually contract and program 1 of 3 related to an intensive services and acute psychiatric care continuum for adolescents. And this is related to a grant that we got. So to the Children, Youth, Family System of Care in partnership with UCSF and San Francisco General was awarded a $33.7 million behavioral health continuum infrastructure grant from DHCS to renovate the 7th floor of San Francisco General Hospital to develop a 12-bed inpatient adolescent psychiatric hospital unit, and the 6th floor of San Francisco General Hospital to develop a continuum inclusive of a 24-slot partial hospital program and intensive outpatient program. So the contract that's before you today is for the first phase of this expansion, a 12-slot intensive outpatient program. The partial hospital program rollout is slated for fiscal year 26-27, pending operational and funding, and the inpatient unit is slated for fiscal year 27-28, pending operational funding. It's also really important to note that this contract and service will bring behavioral services in compliance with offering a day treatment intensive program, which is really exciting. So the intensive outpatient program is going to fill a critical gap in our existing continuum of care of intensive services by bridging a gap between outpatient wraparound and other specialized outpatient therapy modalities for youth that are in need of higher levels of care, and will also serve as a step down for youth coming out of more acute psychiatric placements, like our 23-hour crisis stabilization unit or inpatient settings. The program will serve youth ages 12 to 18 on full scope Medi-Cal, and is a comprehensive program for acute youth, inclusive of day treatment intensive services that operate 3 days a week, Monday, Tuesday, and Wednesday from 3 to 6, with additional specialty mental health services to support comprehensive family-centered care. The program is designed to provide structured therapeutic milieu that fosters recovery, skill building, and emotional stabilization for youth with complex mental health needs. And the IOP will meet all regulatory and clinical requirements and is grounded in evidence-based practices, with dialectical behavioral therapy serving as the core clinical framework. So the contract, the memo you have in front of you has been developed for year 1 for a 6-month contract for this fiscal year. The contract will run from January to June. So we built a budget assuming full operation in clinical care. The reality is the contract's going to start in January, and it'll take time to hire staff and launch services. But this gives you sort of the 6-month snapshot of the operational, who we're going to serve, and the budget to be able to do that work. It is important to note that while we're starting off as a contract year one cost reimbursement, this work and contract will be shifting to the affiliation agreement with UCSF for hospital-based services as we expand the continuum of care and bring on the partial hospital program and inpatient components. So you can see the budget details for the 6-month program without contingency. It's just under 1.2 million. The full year of operation would be double that. It will serve 72 unique clients within 6 months. Again, double that for a full year. 12 clients will be served at a time across within 4-week stays. The budget's broken down into the D-treatment intensive sort of bundled budget, which is just under 670,000, and then the Mode 15 specialty mental health service budget, which is just under 530,000. But all of that together serves the youth within this program. And you can see in the memo that we're working with UCSF to develop highly specialized outcomes to measure critical risk and outcomes, retention in the program, level of care transitions, and outcomes around diversion from higher level of care. This contractor is a really strong performer with other services they deliver through other contracts in our system. They also have a contract with us for outpatient specialty mental health services. They deliver a prevention program called Forte and are also partners with us on DHCS grants to do workforce training and capacity around evidence-based practices. They've been delivering services in partnership with us since 1997. I'll pause there. There's a lot of details that we can go over, but I'll go ahead and take any questions.
Commissioner's question. Are we also looking for public?
Is there any public comment in the room on this item? No public comment.
Okay. Commissioner Guillermo.
So just a couple things that this particular program or this initial intensive outpatient, was that something I might be thinking about a different contract from DCHS, but was that a requirement to be able to get the DCH?
The DHCS grant
Okay.
that we got, the Behavioral Health Continuum Infrastructure Grant, was a grant to renovate. It was a construction grant to renovate the 6th and 7th floor. And part of the stipulations of those renovations is that we deliver this continuum, the intensive outpatient program, and then the partial hospital, and then inpatient.
Somehow I remember that.
Yes,
from a
it was a big
previous-
deal. It was all over the news when we got that grant.
Okay, and then what would trigger the moving of this program or incorporating into the affiliation agreement? Is it just the completion of what's described here, or is it the start of the other?
The start of the other program components, this is starting, the intensive outpatient is starting as a contract, but as we go into the partial hospital program, that is going to truly be a hospital-based service that's Monday through Friday, full day, integrated sort of care, and and then the inpatient, of course, is 24/7 care. So as we launch those components, my understanding from leadership is we'll shift to an affiliation agreement.
And the budget for that will be already included in the affiliation agreement, or is that going to be an
Yeah.
augmentation or some other sort of addition?
There'll be a budget proposal for the partial hospital program that's in development right now for review with leadership.
Okay, and will that come to us?
That's a great question in terms of, I'm going to pause and confer with my business colleagues.
My understanding is that that the affiliation agreement is included in the DPH budget. It's
Right.
like a line item, and sometimes there's some detail, but it doesn't break out into all of these, so it would be rolled up.
Just wondering whether we'll be able to get a sense of the progress or
I'd be happy to come anytime and give you updates on the progress. And I do believe it would be part of the budget that gets presented here and at the Board of Supervisors.
Right, but that sort of it's a generalized budget that gets to us, but because this is sort of something new and pretty
Yeah.
critical in terms of the gap that it's
Absolutely.
filling, that would be good to make sure that
Sure.
we
I-
and the full commission gets a chance to
I would love to come talk about the expansion as we bring on the partial hospital and then the inpatient eventually.
Yes, and I know Commissioner Gerardo is asking for that in different places too.
I was
so-
thinking of her too when we were, yeah, okay.
Yeah, so we could do an update once the program has started and maybe half a year into that to understand how it's moving along. And that'd be a good time to look at the progress for the inpatient service.
Exactly, yeah. Great.
Commissioner?
Yeah. Is this in addition to or in place of the program that UCSF, the residential program that UCSF runs for that same age patient?
I'm not aware of UCSF having a residential program for youth.
Don't they have a KSARC program?
Oh, KSARC has an outpatient, yes, KSARC has an outpatient program for kids that have sexual abuse trauma. And so we do have a contract with them for outpatient services. And I know that they've got work that they do, forensic work that they do through multidisciplinary teams.
So this program is the first of it?
Yes, this is a first.
Okay, thank you.
I would note that they've also commented, because I asked, well, what happens after 3 months? That UC will be developing a process for evaluating the success of the program beyond that period of time.
Yeah, I want to correct my response to that UCSF is going to be, all of the outcomes in the memo, we're going to be working with UCSF to develop tracking for. So the post-discharge tracking, UCSF, with consent of clients to be tracked post-discharge, will track youth up to 30 days post-discharge. For youth that discharge out of care and are no longer in care, we wouldn't be able to have consent to continue follow-up. But for youth that transition to lower levels of care, they'll be monitored, come back to their wraparound program, outpatient program. They'll be monitored through those programs, monitoring and services. So we'll continue that monitoring as a system for those youth.
Yeah, I think that's important in terms of when we get a report back, because that tells us the long-term effect of the program, or whether or not there's some shortfalls that have to be corrected or changed, because that's the ultimate outcome, right? Is how many people really became back into the community, basically. Okay, we're prepared to accept a motion to recommend this to the commission.
I'll move.
Second.
All those in favor? Thank you so much.
Thank you.
We can move on to item 5, request for approval of a new contract with Demure Incorporated. Oh, Natasha? Is someone, could someone, are you, oh, yes, please come up.
Hi, good afternoon. I'm Natasha Lalani. I'm the EPIC Program Director. I also have on the line with me Mark and Devin from the vendor, from Comere. And today I'd like to propose a contract. Comere, the contractor, will be providing a software that integrates with DPH's electronic health system called EPIC to support voice-enabled clinical documentation. The system will allow clinicians to activate a feature that captures conversations during patient encounters and automatically generate clinical notes based on the interaction. DPH intends to use this functionality through existing applications to support documentation workflows. The integration is expected to improve the accuracy and timeliness of clinical documentation, reduce administrative burden on providers, and support effective service delivery across DPH programs. The contractor, Comere, will also provide implementation services, training, support, and ongoing maintenance to ensure the system's functions and reliability within the clinical environment. We will be monitoring DPH. I will be monitoring the effectiveness and through implementation and support lifestyle cycles along with Comer metrics. Also in the packet, you have a budget summary that lists for the first year. The idea is that we would try to get 500 users in the first year. If we were to get more than 500 users, there's a price increase up to 750 to 1,000, and 1,500 is the max on this contract. It would run from December 31st, 2025 until December 30th, 2026 for the first year, and then 2 optional years after that. I'll stop and ask if there's any questions.
Is there any public comment on this item in the room? There's no public comment, and there's none remotely as of now.
Commissioner, to Commissioner Guillermo.
Thank you. Just a question about patient privacy. Will the patient have to provide consent?
Yes, they
for the
would. There would
recording?
be.
And then what are the HIPAA or privacy?
Sure. So we have a consent to treat, and we would have a little paragraph in there letting them know that they would be recorded through the product, through Comer, and that their information would be entered into, just as you did dictation. It's a similar format.
Is there an opt-out?
You can opt out, yes.
Okay. And where has this this system or this particular vendor
Where have they
Yeah.
implemented in
Yeah.
other spaces? Mark or Devin, can you speak to that?
Yes, hi, this is Mark DeLaurentis. Thank you all for having us. I don't know if Devin is able to be unmuted as well, so he can chime in, but the health systems that we work with major health systems across the entire United States, one of the biggest in the country being HCA Healthcare. We also work with UCSF. We work with Summa Health, Adventist. We work with, trying to think who else is on that. We work with Geisinger, Boston Medical, Ochsner, Jefferson Health, Yale New Haven, Sutter. So all the big names, UCA Health, Tenet. We're installed at some of the largest health systems across this country.
with this particular product?
Yes, with this particular product and others as well, but specifically with the Ambient solution, correct.
Thank you.
Thank you.
You're welcome.
Commissioner, I'm wondering when we selected this, had we also talked to our own staff in terms of, or maybe even asked them to look at different options?
Yeah, we actually did go through an RFP process. We did get some feedback about, prior to doing this RFP process, what are the things that the providers would like to see as part of this product. It is an AI product, and AI is vastly moving. So when we went through this RFP process, it was what was available today. There is a roadmap that's available from Comer as well. We have the potential to take any of those things in the later future. Our first record of business would be to get live. And then if there were additional features based off of the need of the providers, we would go ahead and do that.
So now that we have sort of an expert on the line here, tell me what exactly happens. The patient, of course, agrees to having their record be, their visit recorded, I guess. And do they have any edits, or does the physician edit, or this goes into the record and then the physician looks at it? I mean, what's the flow of the document?
Sure. So what happens is that there's a phone application that goes onto your app, just like you have any normal app. You set it down and you can start talking as if we're talking today, right? And maybe there's somebody in the public talking, and maybe there's my child crying in the background. And what it's doing is it's only listening to the clinically relevant information that's happening in the room with the patient. So while my child's talking about, I want ice cream for dinner, I'm also talking about my back pain. So what the application does is it picks up the clinically relevant data and it puts it directly into the note simultaneously. It's within seconds. And then after it's put into note, the physician does have the ability to review for accuracy to make sure that what was said is true. And then it also is available to accept within the chart.
So is there a note that indicates that this was done by
Correct.
by AI
Yes.
and approved by the
Correct.
physician?
Yep, similarly to how they would do it manually today.
Gee, that could almost replace minutes.
Sorry.
Trust me, I'm very excited about that.
Yeah, I'm just gonna say, you have enough.
It's a whole new world.
Well, that'll be very exciting. Okay, is there a motion to recommend this to the commission?
I'll move recommendation for
Second.
approval.
All those in favor?
Aye.
Aye.
This is a random comment, but I don't know if you all have seen the pop culture articles on when people are using chat
GPT.
ChatGPT.
that people's brains are changing and, they're not as smart. And I'm just hoping that that doesn't happen to physicians if they're not
Oh,
doing that. their own
hopefully
jobs.
not. Yeah.
Just a random comment. All right.
That's right. Open evidence for physicians, actually, I think, makes you think a lot better.
Because
Because it actually helps summarize, and in the case of open evidence, also comes out with a whole series of references, which allows you to back up.
and then you review it still.
And then you
you're
can review that and you really get a better understanding of the whole topic.
I
Right.
am concerned about everybody's privacy
Ah.
in this age. And there's a lot of things that might be in my record that I'm not sure I want anyone else to know who doesn't need to, or especially if I were applying for a job or
Right.
getting
Well,
married or.
I'm aware of our city attorney being in the room and that we're off the agenda. So I want to take us back. Because I'm sure you're thinking, what are they doing? Talking about things off the agenda, but your concern is noted. And I think that's something that the DPH can continue to monitor. But we will move on to the next.
Well, no, before you move on, I think in terms of monitoring or understanding the experience that's going on, either it goes down to the various departments and like the JCCs could monitor how this is coming, and the primary care people, whoever it is, but I think that it would be really good to get back a report to let us know how this new technology is really working. And it's informative for all of us. And then I think you could take in the issue also of, how are patients feeling about this? So it's how providers are feeling and how patients are really.
Also, if it can be altered somehow when you,
Oh, safeguards, you mean,
Yeah.
as it comes through, does it get, well,
privacy and safeguards.
Well,
I don't know, maybe they could respond to the safeguard issue in terms of who locks it in and is it corrected?
Could we get that question answered? And did you hear it?
Yeah.
Could you repeat that? It sounds like, well, actually, I don't know.
So I think the question really is, what's the safeguards that, let's say the physician signs off on it, who can change it then? And
Sure. The recording is only temporarily
and who
stored.
can access this?
Yeah. So when you do the recording, it's temporarily stored so that the data can go into the chart. Once it's recorded into the chart, the recording is actually deleted. So there's no way to go back to alter it. Similarly, when you go into a chart today, let's say I'm manually typing out my note, in order to change it, you'd have to do an addendum. That is the same concept that you would have with this, because the recording's not saved.
So this is tracked also?
Sorry?
Is it tracked so that when there is a correction or? does it
Yes,
make-
correct. If you were going to make changes to the note after you had signed it, you'd do an addendum, which is an addition to the note.
All right.
It is,
so
you
it's
can't
like-
change the original.
So it's like a written note that when we write a written note and we want to make corrections, we're supposed to really note
Correct.
that, not just erase it.
That's right.
And so that does the same thing.
That's right.
Okay.
And so does that 6 months or a year make sense for both of you to check back on?
Sure,
how this is
absolutely.
going? It will be ramped up and data will be known.
That's right.
On our end?
Sure. As soon as we have data, we're ready to come back.
Yeah.
I'll check
I
them as
think it'd
well
be
then.
very interesting.
6 months.
Commission.
6 months.
What do you want?
6 months.
6 months. Okay, great.
Okay.
6 months from the
That's just
date
where
of
the progress
implementation.
is going and what we're
Sure.
finding.
Thank you.
Thank you.
Thank you.
All right. I will make no more comments. We can move on to item 6, requesting approval of a new contract with Vertisoft. And we've got Mr. Raffin.
Good afternoon, Commissioners. Secretary Morowitz, Eric Raffin, DPH Chief Information Officer. I'm pleased to share the information about the contract before you for Vertisoft. To clarify upfront, Vertisoft is a reseller. The product that we are acquiring is from the Ultimate Kronos Group, or UKG. And I'll get into what that's all about now. We are proposing this contract, which is a workforce management solution powered by the Ultimate Kronos Group, to help us with a number of activities that deal with the HR workflow, as well as payroll, scheduling, and time and attendance. We are planning on increasing operational efficiency in our recruitment workflow. We are planning to observe decreased risk through eliminating paper-driven processes, most notably around payroll. We are going to offer a competitive user experience with how nurses are scheduled for work, meaning that they'll be able to self-schedule, select their own shifts. We will come into compliance with the enhanced payment program through the state, which is also serving as the funding source for this project. And we will be able to decommission 2 existing information systems that we will just have this one in place of 2. The contract aligns with 2 of our strategic goals. The first one being executing with operational effectiveness, rigor, and financial stability. And secondly, implementing world-class data and analytics to support evidence-based practices. Some key highlights. The efficiency gains we expect to achieve with this agreement are to digitize recruitment workflows. So that helps provide transparency within HR, as well as between HR and customers. We're also going to replace manual processes that have been in place for years due to the lack of a significant information system, such as what we are planning to acquire from UKG. From a cost effectiveness perspective, we're going to start capturing time and attendance information from our largest employee group, which is our nurses, in a digital way. And we will remove paper processes and move that information from this new system from UKG directly to the payroll system in the city, which is an Oracle-based system. So we'll be removing paper and all of the risk of committing errors in the time and attendance process by using a digital system. And errors are going to be discovered before any sort of payroll actions are committed, because the system will be running on a rules-based engine, which means it will consume federal, state, local, and labor rules, and will be able to alert staff when there might be situations where somebody may be trying to schedule for a shift that they aren't eligible for, or if there are any sort of other exceptions in the time and attendance process. And I can't tell you that I've seen how the paper process works today. This will be night and day, a night and day change for all of the nurses. We're also going to introduce predictability and visibility into the hiring process, because we'll have the data and the analytical capability to see how well we're doing. Right now, it's really difficult. We have a lot of spreadsheets and there are a lot of emails, but that's not enough to bring it together to do the analytics that we need to do to see how well we're doing. And we're also going to replace a lot of other analog workflows with digital ones. In some ways, this is like the move from paper-based electronic health records to an electronic health record system. We're moving from an environment where we have files and spreadsheets, and instead we're going to move into an information system that brings all of the data together and brings all of the users together, and it allows us to operate with a much better understanding of how well we're doing, but also to be able to provide more timely decisions, because we won't ever have to answer the question as to, well, which spreadsheet is this information in, or where are we with this recruitment? We'll know that information because the system is going to be able to share that with us 24 hours a day. From a financial perspective, this agreement is just shy of $10 million. That includes about $1.6 million in implementation costs and a little over $1 million in a 12% contingency, which is normal for our IT agreements. As Natasha mentioned a few minutes ago, systems like this often change, and we like to have the contingency in there so that if we see something that we need to make a modification to or add a new feature, that's covered, and we don't need to take any special contract action around that. I'll stop there. There was one question about how this system would improve healthcare delivery. And just as a reminder, this system is definitely not a treatment system. It's not like an electronic health record. It's an enterprise resource planning system focused specifically on workforce management. What we are going to realize with regard to an indirect support for enhancing patient care activities is that we'll be able to use something called acuity-based scheduling, where we will be able to take information from the electronic health record and compare it against the staff who are scheduled on any given day, on any given shift in our inpatient places of business. And as a result, we'll be able to use a risk scoring model to assure that we're balancing the assignments of nurses to patients and make sure that the right number of nurses are available on a given shift to handle the acuity of the patients in the house. Oh, and I hope that clarifies the question that you had. And happy to take more.
And I'll just note this, actually, is there public comment in the room on this item? I see no hands. No public comment.
Commissioner.
Thank you for the presentation. I have a couple questions. One is have you done an estimate of the person hours that this will save in terms of efficiency? And I know it's lots of different staff categories that, you know, will benefit from this, but just sort of generally, the efficiencies come in terms of like person hours or costs or?
The single largest one will be the end of paper-based transcription of timesheet records for nurses that are hand-keyed into the city's payroll system. I don't have, we did an estimate of that a couple of years ago, and I'm happy to go back and get through the records and get you what our estimate was.
Just wondering about the return on the investment. I mean, I'm assuming it's going to be great, but
it should be enormous. The vendor community will say somewhere between 5 and 7 times your initial investment.
that's
as far as the return
an
on
overall
investment.
figure,
Mhm,
right?
mhm.
Okay. It'd just be interesting to know whether that gets realized or how that gets realized, right? Because
Fair enough.
yeah. Then the other thing would be just in terms of how this works. So if, for instance, nursing staffs swap shifts,
Mhm.
I don't know how they do that now, whether that's just sort of between agreement and somebody gets notified, but will that be captured in the system?
Yes.
So, okay, so, and how does that happen? Do they have to enter if they enter the information themselves, or? I'm just wondering because it's associated with the acuity. So if you've got a swapping of clinical staff that aren't sort of the
Mhm.
same level of, I guess, skill matching the acuity of the patient, will that trigger an alarm or?
So that's going to depend on the rules that nursing leadership puts into place for that type of scheduling. If a change is made in advance of the shift starting, that's something that a nurse is going to be able to initiate. If it's something that happens throughout the day, because the nurses are also moving and being floated from unit to unit, depending on demand. Those are all steps that the system can put a hand up and say, hey, wait a minute, we don't need to make sure that we're doing this effectively. It's done today. It's just not done in an information system. As far as ensuring that the right staff are always at the right place at the right time. The system will be able to accommodate what you're asking about, but it will depend on the rules that nursing leadership puts in place.
Okay, and then similarly, like with call outs, if there's a window between the call out and the actual shift, that will be captured in the system, and how will the system make accommodation for covering that call out?
So the system's going to highlight changes like that. And then it still involves, again, either whether it's a nurse scheduler or a nurse manager to take an action. But depending on what's needed. So for instance, if there's a call out far enough in advance and a shift becomes open, we'll have the ability to use tools to broadcast the availability of that shift and do things like use the appropriate model in the labor agreement to prioritize who would be eligible to take a shift. And if we choose to employ it, nurses would be able to see those openings and actually raise their hand and say they're interested in taking a shift.
I would imagine the initial sort of benefit to something like that then would be just the data that's collected in terms of the number, percentage, types of call outs and such, and the actual being able to mitigate the call outs themselves will probably come later, I would imagine. Yeah.
Sure.
Hello, Luana Kim, head of HR. Very, very excited about this product. I think that Commissioner, you had asked about efficiencies. I think there's a few things. The HR team is doing a lot of, and others are doing a lot of things manually through spreadsheets, as Erica said. I'm hopeful that there will be efficiencies regarding the workflows and things like that. We'll be able to capture data, but it will also free up HR staff to be able to provide a better experience and to help with decision-making and things like that. So it'll take away from the sort of manual kind of tasks to really being more partners in helping to advance all the great work within our department. And I think that in terms of the scheduling, as Eric knows the system much better than I do at this point, I know that the staff have been asking for the ability to self-schedule, to have more control over what shifts are available and things like that. I know that the managers are very mindful and thoughtful regarding what schedules they release and making sure that the staff have the appropriate skill level on the different units. So we're really looking forward to this. It's not just going to help on the hiring side. It's also going to help on case management with EEO complaints, labor relations issues, and other things like that. And it will be able to capture data across the entire sort of spectrum. So we'll be able to get more information. So we're very excited about this. Thank you.
Yeah, I mean,
very
it does
much.
sound exciting, and then, looking forward to seeing all of the things that both from an efficiency and from an actual translation to the quality of care and other related sort of benefits. So good luck.
Thank you.
Well, and
Does this involve in terms of the employees, only nurses or only clinical staff or all the staff of DPH?
Great question. So for time and attendance and scheduling, the scope right now is primarily the clinical population, which is going to be folks in nursing classifications.
Okay.
The rest of the tools, as some of the ones that Luana was just speaking to, would apply to all staff. So essentially all DPH employees will have a profile in this system, much like they do in the city's Oracle PeopleSoft system, which is the system of record for things like payroll and your employment with the city. And we would just be sort of taking the pieces that aren't in PeopleSoft and putting them into this system so that we also have a complete system of record for the things that don't go into the PeopleSoft system.
Okay. Commissioner, any questions? Okay. Motions in order?
I'll move to approve.
Second.
all those in favor?
Aye.
Aye.
And Mr. Raffin, what timeline would be appropriate for the commissioners to get a check-in? Like how long will it take to get data so that they can hear how this is going?
The estimate is for an 18-month implementation. This is a really large project. So if we started work, we'd probably be looking at mid 2027.
All right, I'll just note and check back with you so that you all can get.
And we'll bring status reports to our regular full commission presentations as well.
Good.
Yeah.
Good.
Thank
It'd be
you.
nice to get those kinds of reports rather than spreadsheets and having to ask you to reorder the spreadsheet.
Indeed.
Yeah.
Thank you.
All right, we can move on to item 7, the request for approval of a new contract with the University of California, San Francisco to perform felony incompetent to stand trial mental health diversion programming. Hi.
Good afternoon, commissioners.
I'm sorry?
I did have
Oh, it's a show.
Yeah.
Oh, I didn't know. I didn't.
Show just.
Oh, yeah, sure. Oh.
Yeah. Thank you.
Oh.
So this probably, the presentation I just handed to you probably provides more information than you need, but this is for a subcontract between the city and county of San Francisco and UCSF to provide felony incompetent to stand trial mental health diversion services to individuals in San Francisco. It is the contract, the funding comes from the Department of State Hospitals. It's funding for 5 years, and we are subcontracting out the community-based clinical services. So this is specifically for individuals found incompetent to stand trial on a felony charge who the criminal courts deem appropriate for participation in mental health diversion. This is one of multiple initiatives the state has put forward to reduce the number of individuals being sent to the state hospital. This particular initiative is about providing care to individuals found incompetent to stand trial on a felony at the lowest level of care. So rather than the focus being on competency restoration treatment to allow further adjudication of the criminal case, the focus is on linkage to community-based services, as long as the individual meets the criteria of the mental health diversion statute. Mental health diversion and felony incompetent to stand trial mental health diversion were both unfunded mandates passed by state law. Penal Code 1001.36 was the mental health diversion statute, and then Welfare and Institutions Code. It's in the notes. I apologize. I forget the actual specific code off the top of my head, but it established the ability for courts to divert people out of this state hospital pathway and instead into intensive services. So San Francisco was previously providing these services. It was an unfunded mandate. This contract is the state's mechanism for funding those services. So services that were previously being provided or absorbed by jail health services. So for example, all the in-custody assessments of patients, all the referrals and linkage to treatment, as well as services provided by county behavioral health services are now going to be funded specifically for this patient population through this department, the larger Department of State Hospitals contract. This specific subcontract to UCSF is a total of a little over $9 million, a 5-year term, and it will serve up to 16 clients annually with an average length of participation of 18 months.
Is there any public comment in the room? I see no hands.
Commissioners?
Wow. Somebody else asked.
So you're saying we're doing this work now as an unfunded positive
Correct.
medical mandate.
Correct.
Because this is how we're dealing with it. And now the state has come up with funding
Correct.
that's going to be able to allow us to do it under the state program.
Correct. And this is all part of the effort. It's decriminalization of people with severe mental illness, but also providing care in the least restrictive setting.
So,
Where-
so- no, I'll just follow up here is just to ask, how do we select these clients and what if there are more than 16?
So great question. This is really an interesting program because we don't have control over who the patients are that ultimately get served to some extent. So declaring a doubt about someone's competency to stand trial can only be done by a judge or the assigned defense attorney. So they declare a doubt as part of the person's criminal proceedings. The court then assigns an alienist, which is a very outdated term, for a court-appointed psychologist or psychiatrist who does a forensic competency evaluation. So competency looks at two very specific things: the defendant's ability to understand the criminal charges that have been pressed against them and the legal proceedings of a criminal case, as well as their ability to work with their defense attorney in developing a rational defense. So if the alienist decides that due to a mental illness, an individual is unable to do one or both of those things, they then provide a report to the court stating that the person is incompetent to stand trial. At that point, our criminal court judge issues an order to both currently to Jail Health Services to do a mental health diversion eligibility assessment. Simultaneously, they refer to Golden Gate Conditional Release Program to make a placement recommendation for competency restoration. And then when the judge receives both those reports back, they make a decision as to whether they're going to allow diversion out of the criminal justice system to treatment, or if they're going to have the person go to the state hospital where the focus is on competency restoration so that the state can continue the prosecution of this individual. And so again, the decision around mental health diversion is also up to the judge. So one of the things this contract will fund are much deeper, much more comprehensive assessments of the participants. And it'll in fact include a violence risk assessment, which is something Jail Health is currently unable to do because it puts us in a dual role where the patient's treatment provider, we can't also be doing a forensic risk assessment. So this will fund services specifically to do that more forensic risk assessment, which will then be shared with the court, including the district attorney and the public defender. So when they are deciding, while it's ultimately the judge's decision, the information can help guide that decision, but also provide information to other criminal justice partners around the appropriateness of diversion versus state hospital placement and ultimately continued down the path of prosecution.
Wow, okay.
It's a lot of information involving many different systems, both the criminal justice and the healthcare system. And the overlap is definitely complex, but ultimately it's very specific services for a seriously mentally ill portion of our population. And the goal is to reduce the criminalization of this population. The larger contract provides funding for housing. So I really see it as part of our overall goal to reduce the criminalization of the mentally ill, provide wraparound services, reduce recidivism risk, promote psychiatric stability.
Thank you. Further questions?
Yeah, so in looking at this one sentence about the legislative changes and shifting the responsibility from the state to the localities. And all the things you talked about, have we got the services here that will accommodate
That is a
Uh-huh.
great question. So on one of the pages, there's the legislative timeline, which I think you were referencing. And you really see this move since 2018 to, as you said, shift responsibility from the state to local counties. And the state, there's a lot of different ways that it's framed as, least restrictive setting. But ultimately, it's really the state wanting counties to take responsibility for the care and treatment of this patient population. And they are also under tremendous legal pressure due to multiple lawsuits to reduce the state hospital wait list for this incompetent to stand trial population. And so I kind of equate it to AB 109, which shifted state prison inmates to counties.
Do
I
we
mean,
have it,
obviously
though?
what's that?
Do we have what it takes here, or are we going to have to build it from scratch, or are we halfway there, or what?
I believe certainly this contract will provide critical services for this specific population. At the end of the day, these aren't new patients. These are the same patients that are on our streets, in our communities. They just happen to be coming through a different door on this day. Ultimately, I think certainly there's always a need for more services, but I think these are the same patients we have now. I think this is just more directly connecting them back to their communities instead of going via the state hospital. And while the state hospital, the treatment they provide is valuable, it's really about competency restoration. It's not about integration back into communities. And so what I see is really a positive of this is it's really focusing on integrating people back into the community, getting them treatment in the community so that they learn how to live in the real world and not behind the walls of a state hospital, and manage their mental illness or their substance use disorder in the community.
Okay.
So ultimately, it's the state now paying for obligations they've asked the county to take on.
It's the state funding critical services in the communities. Yeah.
Okay. If no further comments, a motion for recommendation to the commission.
I'll move approval of the recommendation.
Second.
All those in favor?
Aye.
Aye.
So can I just say one thing?
Could you say aye first? Could
Sorry.
you say aye just to make sure I didn't get a vote from you? Could you say aye so that we have on the record that you
He's
voted?
looking for an aye first. If you're going to
Say yes for the
this,
vote?
then you can.
Aye.
Okay.
Aye. Oh, I said aye.
Yeah.
Said
Okay.
yes. So I know we've been here before. We've had state hospitals before. We had local programs before. I'm just hoping this one will be more, that we've learned from all those past experiences, and this one will be more successful.
Yes, me too.
And we will get data on that and you will get updates, so you will hear.
Yes, absolutely.
Thank you so much.
Good to see you.
Good to see you too.
Thank you.
Item 8, Health Commission duties and powers regarding DPH contracts and grants. And commissioners, this is the beginning of a discussion. This meeting will not be the end. This will be just the introduction of you all diving into this.
Thank you and welcome.
Thank you so much. Good afternoon, Commissioners. I'm so happy to be here. My name's Ann Pearson. I'm the Chief Attorney for Health and Human Services with the City Attorney's Office. Several months ago, Secretary Morowitz reached out to me to ask that I prepare some information about the Commission's authority and duties relating to contracting. And I was very excited to get the request. Commissions have enormous responsibilities and oversight authority. Commissions are asked to do so much. So I always think it's wonderful when a commission decides to sort of push pause and take stock of its own policies to see how they're working and how they serve your mission. I'm primarily here to answer questions you may have, but before that, maybe I can take just a couple minutes to summarize some of the information that we've shared with you in our memo. In a nutshell, the memo talks about two things: when the commission must act on contracts and when it may. So I'm going to start with the charter and talk about what the charter requires of commissions with respect to contracts. The charter includes a long list of things that every commission has to do, but reviewing or approving contracts is not one of them. And that comes as a surprise to many people because most commissions do look at contracts, but they don't review them because the charter requires it. But the charter does authorize commissions to adopt policies that serve their oversight of the department or facilitate their own procedures. And many commissions do have policies regarding the contracts that they would like to review. And the Health Commission has just that. I think it was last updated in 2015. Is that right?
Yes.
So it's been 10 years, which sounds like a perfect time to take a fresh look at it. These policies vary from commission to commission, but I think as a general rule, each commission is trying to find a balance between the contracts they want to review because they're very significant contracts, either amount of money or the services they're providing, and their particular expertise that the commission can bring to bear, and weighing that against the other many competing interests and issues that they want to take on behalf of the commission and the department, as well as the staff time that it takes to prepare things to come here. So, like I said, every commission is different, but you do have the authority to come up with a policy that finds the right balance for you. While the charter does not require commissions to review or approve any contracts, the Board of Supervisors has adopted a couple different pieces of legislation that do require your review and approval should the department wish to bring these types of contracts to you. And generally, those are sole source agreements. As I'm sure you're aware, we have legislation in San Francisco that typically requires departments to go through a competitive process before they procure a good or a service. That is sort of the default rule because of the value of competition. But the Board of Supervisors has acknowledged that there are certain circumstances where it's actually appropriate to enter into a sole source agreement. And typically that's when there's a belief that there's really just one person who can, or one entity who could provide the service. So it wouldn't be a good use of anyone's time to cast a wide net. In those circumstances, the Board of Supervisors has required through their legislation that before a department enters into one of these sole source agreements, that they first go to their commission to provide the justification to say why it is they think that it's appropriate to deviate from the norm in this case, and for the board to approve that rationale and designate the contract as sole source. In addition to the memo, we've provided you with some materials, including a copy of your most recent policy. We have the OCA guidance on sole source grants. We have a memo that was issued previously by my office relating to Commission's review of sole source grants. And with that, I'm happy to answer any questions you have about any of those materials or what I've said today.
Is there any public comment in the room? I see no hands, so no public comment.
Yeah, so thank you for presenting this and reminding us that it's been 10 years since we evaluated the process. And prior to that, I thought we'd just add a little historical note to this, that back when the commission was first formed, and Dr. Phil Lee was our president of the commission, one of the things that he was basically trying to do was to increase the transparency of the finances of the department. At that time, the finances were fairly decentralized. and contracts being part of it, perhaps. But definitely, different divisions held their own funds, and there was some concern on the part of both the mayor's office and the board office and the board members that not everything was as well understood as it should be. And so President Lee at that time was putting into place a process to understand what all the various expenditures were, what the contracts were about. And I think is one of the reasons that they established the first review of contracts, which were, if I remember, fairly extensive. As we went along, it became apparent that contracts over or I should say, under a certain amount did not seem to be of value from a time standpoint for everybody and effort standpoint. I think we kind of used the 90-10 rule, and that the contracts that are presented to us with about a $100,000 general floor, at least, would then be the ones that we should look at, because that's really the high risk contracts from a financial standpoint, and also for performance. And so that's kind of the background, and the last iteration of the contract was trying to, of the contract protocol, was to try to streamline this and help reduce, and all the way along, we're trying to help reduce extra work on the part of anybody, use what was already there. But then sometimes it became a problem, because then we'd get original documents, and the next thing we knew, then the commissioners were reviewing original documents, trying to do an evaluation all over again. I think the current process at the moment is trying to refine that, and yet maintain the principles that high-risk contracts, both financially and performance-wise, are really the ones that the commission really wants to look at from a contract side. From a budget side, which is not in this contract, but as an aside, the budget streamline, the budget that we have and will be presented today as a quarter, was also the result of trying to find the right balance so that the commissioners and the public would understand fully the finances of the largest department in the city. And I think considering all the people who have been working on this, the current iteration is really a refinement of where we were before. So there's been a lot that has actually been done since the commission came in order to create a responsible and reliable financial status and responsibility for looking at cost expenditures, whether it be in contracts or personnel or whatnot. So that's just, I think, an important background to understand then, as we continue to try to see, well, what is really going to be helpful. And with our new director, who's a whiz at all this, perhaps we could strike that wonderful balance that says, from a contract side, what I think we would like to do is see a contract, understand what actually had been done, if it's as a renewal, and if it's new, to understand what it's supposed to be doing. What are the outcomes expected, and in previous contracts in the review, what really did we do that make that worthwhile so that we can renew the contract? Or in the case of the fact that we understand it takes a lot of effort and work to create a contract, and we allow 10-year contracts, that we only implement the first several years to understand how well it's coming. And at that point, we definitely would like to see what is the product that we are creating, and what outcomes, how successful have we really been? Is there, if we're going to renew this or add years to the contract, what are we expecting that may be different? So that's kind of just the general context, I think, in which then the protocol protocol has been refined and developed.
Mhm.
So Commissioners, your thoughts now on this, and I would suggest that it would be good that we look at this today, ask some questions, and give us a feeling as to what direction we want to take in this review process. And then how we would bring this back to you.
And just to know, we have like 10, 12 minutes-ish to begin this because we got to set up
Sure.
for the other meeting.
Commissioner Guggenheim, do you have some thoughts right now?
No, but I'm sure I will, but I want to hear what everybody else has to say first.
Okay, Commissioner, you're.
Well, I appreciate the history and
Yeah.
the rationale for how we've moved from how we started to where we are now. My thoughts on this are, I really am in favor of continuing to streamline. And I wonder if, and I don't know how much the number of contracts has grown from when we started reviewing them to when we did the first streamlining to the next, but it would appear to me that they've grown quite a bit. And so that, that's something, not just the amount, but the sheer number is something that I think we have to look to and ask the department how best to streamline those and then come to us in a streamlined fashion for approval. But I would agree that from a responsibility and accountability standpoint for this commission, that what Commissioner Chow mentioned in terms of, you know, what are we supposed to be getting for the investment that we're making on a renewal or on a first-time contract is really sort of the oversight that is our responsibility as opposed to the minutia of the process for how things, because we end up getting into that because oftentimes that's what you sort of ask questions about what you're being fed, as opposed to sort of the bigger picture sometimes. So those are sort of the thoughts that I have. I don't have anything other cohesive to add at this point, just generally that more accountability, more ways to help with the accountability process and the the outcomes that we're getting relative to what we're expecting, and then the streamlining to the extent that, it just eases the burden both on staff and on members of the commission to be accountable.
Commissioner Guggenheim?
My my feedback as I read this and and yellow lined it and everything is that I sometimes worry in this city that we have so many cooks that the broth gets ruined and it takes forever. And that the people who are doing the actual work would prefer to have the responsibility. On the other hand, when I was listening to Commissioner Chow earlier, and he was talking about what it was like before, it was clear that some kind of oversight was needed. So my feedback is that I want to balance those two things. Not that I don't have opinions, but I don't always need to have my opinion in every decision. And I don't know how to balance that, but that's where I think we should go.
So I think some of the areas that we can look at, that we should put down and see is to understand with the contracts as they are now, what is the 90-10 rule, or should we follow somewhat less? And potentially we could reduce the number of contracts in 10 years, there's been some sort of inflationary factor, right, over the 100,000, and maybe we're at 200,000 or 500,000 in order to capture what we were trying to find, which is the biggest bang for the buck, looking at the largest contractors. Maybe there are also some key services that we should be looking at, which we've not really done with, that might be another way of looking at things, or maybe the Finance Committee should really be also then. We've been trying to look at mega contracts, so that's another area. How could we do that? How do we put that kind of on a regular basis?
And if I can interrupt, that's just vendors with a lot of contracts when you talk about that. So I want to make sure that Ann knows what you're talking about when you say mega contracts. It's like someone like
Right. Exactly. Thank you for the translation.
And I apologize for interrupting.
Yeah. And so I think there's also a need to understand what's on the watch list and how we monitor the watch list in order to understand I'm sure still do have a watch list of vendors or contractors that we're concerned about. That comes up somewhat in the fact that we now get the fiscal reports. So that has been helpful, but to understand maybe periodically what we're doing with those so that it isn't forgotten or that we get surprised that suddenly we've been working with contractor X and for a year and a half, and now we're reading it in the Chronicle. And perhaps we didn't even know that it was under that scrutiny. So that's another thing. I thought we've talked about the need in some way to understand outcomes better and easier. So I think in today's example, it isn't so much that we needed to know that there were 35 hours for this or that, but that in fact that took care of 16 people, and that 5 of those people were successful or something like that. That's kind of really what we're trying to look for to understand. So those are just some thoughts that we're giving here to the secretary, and that may be worked out as we look at some of the parts of the protocol that said what contracts or what vendors are actually bold for us to look at and how to do it. And then how do we oversight on mega contracts? And although it sounds like we're breaking them down again, and like I said, we might want to do about maybe special services, or maybe even looking at smaller populations and whether they have gotten forgotten, because they're not very big contracts. But we don't really understand exactly what we're doing with the American Indians. Once in a while, those contracts show up, but only because they're part of a larger contract. So that might be another area that the commission might like to emphasize.
May I ask a question related to what you're saying? So if you all change the policy and review less contracts because you maybe changed the threshold, would you be interested in somehow monitoring what the DPH is doing with those contracts to ensure there's a process that the monitoring is taking place and that it is solid, even though you're not the ones doing it? Because you're going to be seeing less and actually touching less and then trusting the DPH more, which is the way it should be. But then therefore, you're not going to actually be seeing how those contracts are doing. And would you be interested in reports or I don't know how that would even work, but are you interested in knowing about those contracts, or they're going to be out of sight, out of mind?
Well, it seems to me that the real question that we've all been asking are outcomes. A fiscal note saying that it has been passed or approved with this, or more importantly, like today, there was an issue, or last meeting, there were late audits and whatnot. Those are kind of flags that we, I think, like to see. That is the areas of concern. But that's just my thought. Any thoughts in regards to the question? Because I think Mark needs to get some feeling as to how we're going to, and I would think the next thing we might want to do, talking about Mark here, is maybe to start looking at some modifications with the data, of course, behind it, that we might want to entertain or look at and how that does. And I think working with our director, who, like I say, is not kidding. I mean, he's skilled at these things in terms of helping us to be efficient and yet be able to do our duty.
This is a really good discussion. Thank you, Anne, for the framing of it. And I think Commissioner Chow, the way you framed, you said something before. You said, should have written down, try to balance making sure that things that have some level of risk, either from a financial or some other policy, stakeholder, optics, clinical, those are the types of things kind of threshold wise, as well as trying to really understand outcomes overall. And so maybe just a few thoughts that, and then we anticipate just kind of thinking about this and coming back with a more multifaceted proposal. I think there's clearly one prong, which is how do we make sure right now we're not hitting the mark on, you're seeing the vast majority of everything, and therefore it is harder to triage for everybody, including the commissioners. What are the things to really go dive deep on and understand risk level or have the robustness of discussion needed? It's just hard when you have as many contracts as we do, and functionally everything is coming forward. And so that is one piece. And on that one, I've asked the team just to be fact-based, to go pull some data, to look over the past, call it a year or so. What are all the contracts? What are the size of them? What have we seen of what's come before the commission, so that we can think about how to recommend the right balance of thresholds between new contracts, sensitive contracts, contracts that are under monitoring, all of that sort of stuff, to better strike that balance so that the engagement is more meaningful versus peanut buttered all over. And so that clearly is one thing that I anticipate based on this discussion, us coming with a collective recommendation on. And the second piece, as you noted, is how we understand outcomes overall. And there's a range of ways that we are thinking about on that. I think it might make sense to put on one of our upcoming agendas a readout of all of the different performance management and contracting initiative work that we're undertaking in the department. Some of the contract, it is hard to have an outcome in the sense of HbA1c control, like the way you can in classic healthcare quality measurement. But we are trying to get to more of that depending on the contract. And at a minimum, we are trying to get to absolute number of people served under a contract, and what is the cost per person served in some sort of way that is more intuitive than when you look at these UOSs and UDCs. It's hard to internalize that, to really have a sense of, are we being efficient with our CBOs in actually reaching, even if we all agree on the outcomes. And so those are things I would anticipate us bringing forward more substantively in the types of contracts we're looking at, or in describing what the cost per individual is across a whole range of services, for example, within behavioral health, so that the commission can see a more global picture of it versus the one-off contracts that come before you all, and you have very little point of comparison on which to kind of judge the effectiveness of a particular contract.
Yeah, it reminds me that I think at one point we had a series of strategic principles, and we were tagging contracts to those. And I think it's important for us to understand, again, you're right, a lot of the contracts come in, we're not sure where they're standing. It's sort of similar to when we get presentations, except that today we're getting it within an org chart where they're telling us at least in which division they're coming from and so forth. We don't have that with the contracts. I know that when you did your CBO one, you separated them into sort of preclinical, clinical, and then facilities or something like that. But so I think that's one thing. Contracts need a context as to where they're from, right? Or trying to solve, or coming from. I guess when we put in place the Epic system early on with a huge budget, we actually required, remember, that they tagged them when they brought the contracts to us and tied them to the budget. And it was really nice to know that these 5 contracts belonged into this information system and that we were dealing with those 5. So that's another sort of iteration of how do we do these? I mean, if all the contracts were in 1 month, they would of course be easy to categorize but we would never be able to do that for the 100 contracts. But that's one of the things. We don't really know where the contracts, belong in terms of the types of services being done by the various divisions.
I'm sorry to interrupt, and before you speak, I just want to note we're short on time. So
Yes.
if we could maybe have a comment or two and then wrap it up, that'd be great.
Go ahead.
So following along with what you're saying, I think too, it would be helpful if we had a list of the 5 important things to keep our eye on all year long, or something like that, so that the contracts would fit into that. But other decisions we made would also fit into that.
So I think if we all think about this, I think Mark was proposing that we go through these or have this topic over the next several meetings.
Right.
So that we could refine this. So Mark, you think you would us to have more open dialogue, or you want to start with a area potential, or perhaps you could even bring, this might be easier, bring how many contracts are in this 90-10 block that, and work with the department to see what they might think would be a good breakout, and maybe reduce the number of contracts requiring the formal review process.
Yes, and I know, as Director Sy just said, they're planning on bringing you proposal related to that so that you all aren't creating the policy. They're going to kind of spoon feed and say, here's what we're thinking might be best. And then you all can interact with that. And that probably won't happen, I think, till March, April. I think it's going to take a little time, from my understanding. But in the meantime, you all can keep doing your homework and I will serve you any way that I can. So I think you and I can keep talking offline around what should happen at the next meeting.
Right, and let's keep this on the agenda.
Yeah.
So that we'll present it at every meeting. And just think about it and bring your thoughts.
And thank you again for your.
And thank you very much for the summary and for the document. It's very helpful.
Okey doke. So let's move on to emerging issues. Hearing
That
none.
was it.
What?
That was the
I know that is
emergency.
an emergency issue. Any public comment on that? No public comment. And then general public comment? I see none. And so please consider motion for adjournment.
Oh, move, second.
All those in favor?
Aye.
Thank you, everybody.